from the Department of Clinical Microbiology at AIMS Mangalgiri. Before we start, I just wanted to brief that there are certain queries and questions that came in the chat boxes and otherwise in the messages also in my WhatsApp regarding some confusions regarding the pharmacokinetics and pharmacodynamics of antimicrobials and how they are important in clinical practice, and why the both the clinicians and the microbiologists they need to know about the pharmacokinetics and pharmacodynamics. So just I'll be briefly explaining the the PKPD and the different PKPD indices in this presentation. So what I would be speaking about is revisiting the basic definitions of pharmacokinetics and pharmacodynamics. What are the different PKPD signatures or the PKPD indices of the antibiotics? What are the pharmacokinetics and the pharmacodynamic targets? What is the probability of target attainment? And what role does the MIC play over here in this case? And how does all this balderdash help me in my clinical practice as a clinical microbiologist or as a clinician, as a surgeon? And what should a clinical microbiologist should follow? Should I follow CLSI or the EUCAST when it comes to dosings? So certain AST concepts that we need to know is that antimicrobial susceptibility testing is not the same as the usual investigations that we send for the labs, because in the usual investigations the data that we are actually capturing is the analyte. Like for example, if you want to check for the sodium potassium levels or the hormone levels, we attempt to directly detect the analyte or tag it with some detection mechanism like a fluorescent antibody. uh, for example, in lab, if you want to detect any antibody or antigen, we do it through immunoassays or the, like for example, CLIA, chemiluminescence immunoassay, or the ELISA or the alpha or the lateral flow assays, or any of the your ELISA rapid and simple based tests. Whereas AST is different because we are not detecting any analyte over here. We are just observing that at some point, somewhere in some kind of a medium, which could be an agar or a broth, that allows the growth of bacteria to grow. Some antimicrobial substance is there which is inhibiting the bacteria. And then ultimately, we extrapolate this observation into an in vivo action, that is, to administer the antimicrobial drug to the patient and we test it in the lab. It does sound very ridiculous, but we have standardized these techniques over the years, which will give a very fair result. So before we proceed any further, let's talk about certain terms to our clinical colleagues, like breakpoint. So breakpoint is that you can say a concentration where we can safely predict that this would be the response of an antibiotic against a broader population of bacteria. So breakpoint is just a scale, where we decide that above this it is resistant and below that it is susceptible. So it is basically a concentration that separates the various populations of bacteria, and is been nicely given in this book by Victor Lorian, which I have referred to. The susceptibility breakpoint is again same concentration where we can safely predict that the drug will be clinically effective against a broader population of bacteria in the usual doses. So I've made these two statements, or we can say these phrases as bold: clinically effective in the usual doses. So therefore, what we use as breakpoint is nothing but a scale that in terms of response, if it is responding, that means it is susceptible. If it is not responding, then it is resistant. If you look at the basis for the PK and the PD, pharmacokinetics involves the absorption of the drug, the distribution of the drug, the metabolism, elimination, and the protein binding. Basically, what the body is doing to the drug the moment you give the drug to the patient. Whereas in the pharmacodynamics, the drug that ultimately reaches the site of the action, how it is exerting its effect on the target pathogen, how there can be drug toxicity or side effects. All these are the pharmacodynamics. So basically, what the drug does to the bacteria in this case, or otherwise the body. So if you see this arrow over here, we can see that usually we begin with a dose that reaches a particular concentration in the serum, that reaches a particular concentration at the site of the infection. After undergoing all these pharmacokinetic actions, the body has to take on it, like the absorption, desorption, distribution, metabolism, elimination, and protein binding, and the ultimate concentration that reaches at the site of the infection, which exerts its biological effect. So if that concentration is much more high than the MIC, then definitely it will be a very effective drug. But if it is just at the level of the MIC or maybe below that, then in that case the bug will not get affected. So if you see, the kinetic means the moving, what the body does to the drug. So we have got absorption, distribution, metabolism, and excretion. All these are subject to a different maybe presentation sometime. Otherwise, how all these things like bioavailability and what are the different food interactions that will affect the intake of the drug and the ultimate concentration and the site of infection. So if we take an antimicrobial and give it parenterally to a patient, then it increases in concentration in the serum. It reaches a maximum concentration that we call as Cmax, and then it slowly falls down. So this total area under the curve gives you that total amount of dose, single dose that has been given to the patient. But at the same time, on the basis of the physiochemical properties of the various antimicrobials, they are broadly divided into three categories. In fact, two, in fact, but the third one is lies in between. The first one is the concentration dependent antibiotics like aminoglycosides and quinolones. These are drugs in which the higher concentration of the antibiotic is more effective than giving it into divided doses. So such antibiotics will be effective only when the high concentration is reached in the serum and therefore the site of the infection, and they are the ones which cause the good post antibiotic effect, and therefore, like for example, aminoglycosides acting on the 30s ribosome and quinolones acting on the DNA gyrase. In the other spectrum is the time dependent antibiotics, which are the ones which are acting on the actively dividing bacteria, especially on the cell wall, like all the beta lactam agents, and that is why they have to be given in slow infusions or increased exposure or increased frequencies so as to keep on acting on the actively dividing bacteria. So that's why we don't give the beta lactam drugs as OD doses. They are usually given at least as BD doses or 3 times a day doses, and that too as extended infusions. The only exception being ertapenem, which acts like a concentration dependent antibiotic. Then the third variety are the ones which are time dependent, which have got time dependent killing with moderate to persistent post antibiotic effect, and these are they are measured by three different PKPD indices. So the PKPD index for the concentration dependent antibiotics is Cmax to the MIC. So that is the maximum concentration achieved in the serum divided by the MIC. So higher the MIC, lower will be the PKPD index, and therefore lesser the effective the antibiotic would be. The next one is the time dependent antibiotics with like the beta lactam drug. So the increased exposure is more important. So they are indicated by the percentage of the time when the concentration is above the MIC. So, like for example, if the dosing of let's say ceftriaxone is 12 hourly, and the MIC for enterobacterial is, let's say for example, is 1, and for in the 12-hour dosing period, at least 6 hours it is above 1. The concentration of ceftriaxone is above 1. So that means the PKPD index for ceftriaxone is 50%. That means 6 hours divided by 12 hours, that is 50% of time of the dosing interval, it is above the MIC values. The third one is the total amount of the antibiotic given to the patient, which is the area under the curve divided by the MIC. So the constant denominator in all the three PKPD indices is your MIC, and if the MIC level rises, then definitely the efficacy of the antibiotic will fall. So as we can see with this table that we have got the concentration dependent antibiotics which have got a good post antibiotic effect because they're acting primarily at the genetic level. The time dependent antibiotics which have got a poor post antibiotic effect because they're acting on the constantly dividing bacteria, multiplying bacteria. And the third are the time dependent antibiotics which have got a good post antibiotic effect like the macrolides, tetracyclines, and the glycopeptides. So ultimately, the reason for the post antibiotic effect is that the protein bound drug gets eluted or released slowly into the serum, thereby having a constant levels of the drug being available in the serum and at the site of infection for the efficacious killing, and also that they cause damage to the genetic machinery like the aminoglycosides acting on the 30s ribosome, fluoroquinolone acting on the DNA gyrase, and the tetracycline and also acting on the 30s, the clindamycin, the lincosamides acting on the 50s ribosome. So all those the antibiotics which are acting at the genetic level, they are likely to create a good post antibiotic effect. So if you just remember the basic fundamentals is that if you want to alter the dose, that means the if you want to go from 15 milligram per kg of amikacin to 25 milligram per kg of amikacin, so it is primarily going to affect the Cmax to the MIC ratio. and also of course the total amount of the antibody given, which is represented by the area out of the curve divided by the MIC. Altering the dosing interval, that means if you're increasing the frequency, that will, of course, if you increase the frequency, the total antibody given will be increased, of course. So again affecting the AUC to the MIC, but at the same time the percentage of the dosing and percentage of time of the dosing interval when the concentration will be of the MIC will also increase. So basically for the time dependent antibiotics, the rate of the bacterial killing will be maximized at lower multiple of the MIC but at increased exposure, and therefore achieving higher concentrations will not really result in greater killing. So if you think of giving maybe 2 grams of meropenem over 30 minutes, that is going to be not as effective as giving 1 gram of meropenem over 3 hours. Similarly, for the concentration dependent antibiotics, you have to maintain a high concentration in the serum, especially in conditions where the volume of distribution might get increased, like in patients with the renal replacement therapy, RRT, or ECMO patients. All these patients, the volume of distribution is very high, so in that case the overall concentration of the antibiotic will fall. And also because the inherent property of certain drugs like tigecycline, which has got a very high volume of distribution, and therefore they get distributed in this virtual space and do not remain in the serum and in the blood, and therefore drugs like tigecycline are not good for primary bacteremias. They are only good for the secondary bacteremias which arise out of the complicated intra-abdominal infections or skin and soft tissue infections. So that's the relation between the different PKPD indices to the MIC. So if we try to understand what is the probability of target attainment and what is the relation with different PKPD signatures, we'll try to understand on the basis of our education system. Let us say we have a student who aims or targets for 85% marks in class 8 and he gets 85%. So his strike rate is 1. That means he aimed for 85, he got 85. So his probability of target attainment is 100%. By the same time, when he aims for 100% in class 10th, that means a higher class because the boards and he needs to score better, but he gets only 90%, then his strike rate is 90% or zero point 0.9. So, despite that he has scored more than what he did in class 8, his strike rate is less. Similarly, the same concept can be extrapolated to our PKPD signatures and the probability of target attainment. So, target in this case is the adequate action or the maximum kill uh, of the bug by the antibiotic at a breakpoint MIC. That is, if the percentage of the time when the concentration of meropenem is above 1 microgram per ml, which is the breakpoint for meropenem, for 40% of dosing intervals. So that means in that 40% of dosing interval, I have achieved 100% killing at an MIC of 1. So that means my probability of target attainment is 100%. Again, to put it in simpler words, if I am able to treat my patient with meropenem dosings of meropenem dosing of, let us say, 1 gram TDS over a 3-hour infusion with an MIC of a E. coli isolate of 1, and the patient gets cured, so that means uh, my target is achieved. So that means I have attained maximum kill or the adequate action. So in this case my probability of target attainment is 100% because I have kept the dosings of meropenem in such a way as the extended infusion, so that the concentration of the meropenem 40%, at least I'm saying 40% of times it is above the MIC. So your minimum probability of target attainment should be 100%. It can go high as 120%, 150%, maybe 200, 300, 400%. But the minimum should be 1 or 100%. That is why you can have the concentration of the meropenem might be maybe 8 microgram per ml throughout the entire dosing in the entire day, despite having a tedious dosings. But still, you will be having much better kill because it is above 100% and you have adequately achieved that maximum kill. Now, if we extrapolate the same thing, that if the MIC of this isolate went to as high as 2, so in that case, would that probability of target attainment will be achieved because now the bug is little more resistant. So in that case, I will have to either change my dosings or have to increase the frequency or increase the concentration depending on the pharmacokinetics and the pharmacodynamics of the particular drug. So that is the purpose of just informing what is the different PKPD targets. So, like for example, These are different types of PKPD ratios and targets for the best clinical efficacy. For when we have antibiotics like the time dependent antibiotics like cephalosporins. So, in such cases, at least 50% of the dosing interval, the concentration of the cephalosporin has to be above the MIC. Similarly, as I mentioned in the previous example, for carbapenems, it has to be 40% of times the MIC, the concentration of the carbapenem has to be above the MIC. If it is less than that, it may not create that adequate kill. Same thing goes for those antibiotics which have got a concentration dependent kinetics, like for example aminoglycosides. In that case, the maximum concentration reached in the blood to the MIC ratio should be at least 8 and above 8. Same goes for fluoroquinolones and for polymyxins. However, there are conditions and situations. These are the usual conditions when their MIC has increased. So in that case, you may have to give 15 milligram per kg amikacin not as an OD dose but as a BD dose. So you're not dividing that single dose into 7.5 and 7.5. You are adding 15 milligram in the morning and 15 milligram in the afternoon or in the evening as two doses. So you have totally increased the overall administration of the antibiotic of amikacin in that patient. So in that case, the PKPD dynamics, they shift from Cmax to MIC to area under the curve. That means you increase the total overall amount of the antibiotic given to the patient by increasing the dose of an antibiotic which normally had the Cmax to MIC PKPD indices. So in that case also, that's the reason why aminoglycosides has been put into this table also, because there are certain situations like I have mentioned in this particular table. PKPD index for aminoglycosides can usually it is Cmax to MIC ratio, but it may be shifted to the total amount of the antibiotic given to the patient. Like for example, you have a NDM opsa positive CRE infection of the, let's say, the pyelonephritis, right? And it has got an E. coli, and you know that through the ultrasound maybe, or there's a renal abscess in that case, the pyelonephritis case, and you've got an E. coli, and the only antimicrobial that is susceptible is, let's say, amikacin, because amikacin gets nicely concentrated in the renal tubules. Among all the aminoglycosides, amikacin ones is the one that gets nicely concentrated. And in such case, if the MIC is in the susceptible range, you can comfortably give the normal single OD dose, maybe 15 milligram per kg body weight. But I would personally prefer to go in for the PKBD dosing in such case, in which case I will follow the EUCAST dosings of amikacin, which is 25 milligram per kg body weight, not 15. Similarly, if it is in the intermediate range, again you might have to go for the highest OD dose, again the PKPD dose of 25 milligram per kg to 30 milligram per kg body weight for your omega-sin. But if the MIC is in the intermediate range, or so you'll have to push it much higher. So you might have to go in for as high as 25 milligram per kg body weight BD. So the total amount of antibiotic you have increased. So the A that in that case the PKPD index shifts from Cmax to MIC to the area under the curve is to the MIC ratio. So AUC 0 to 24 means that during that 24-hour period, what is the total amount of antibiotic that has been given to the patient. So that is the meaning of AUC 0 to 24. Same thing goes for the time dependent antibiotics like beta lactam drugs, where the extended infusions have to be given, or you might have to give continuous infusion if the MIC is in the intermediate range. So in case of continuous infusions, you are able to maintain a concentration at a constant concentration above the MIC in a continuous phase, because these are the antibiotics which are acting on the actively dividing bacteria. Same goes for the other antimicrobials which are enumerated in this particular table. Now, this is also a very interesting table that I've put up, that these are the beta lactam antibiotics and the other fluoroquinolones, aminoglycosides, and glycopeptides. And how this PKPD index means how do they work? That means for the beta lactam antibiotics, the percentage of the dosing, percentage of the time of the dosing interval when the MIC values are when the concentration of the antibiotic are above the MIC values. That is the meaning of this. That means fraction of the time of the dosing interval when the concentration of the antibiotics is above the MIC. Same thing goes for the aminoglycoside, Cmax to MIC ratio. This means how effectively they work. That means the PKPD target. That means if that I know that percentage of time, what percentage of time, how much percentage of time it has to be above the MIC. So which I showed you in this previous table. So these are the PKPD targets which are there, and uh, for the antimicrobials, for those bugs in which the MICs are in the susceptible breakpoint range, whereas when they are slightly higher, we'll have to push the antimicrobial little more. And how much more can you push the antibiotic? This is the fourth column where the PKPD indices, they will tell you at till what amount and what concentration and what at what level, till what level can you push that usual PKPD target to. So if the Cmax to MIC ratio is 8 for aminoglycosides, and in this case let us say I get an MIC of 2 and my breakpoint is, let us say, 2, so 2 by 2 is 1, so I would like to further increase the dose or the frequency of the antibiotic, and up till what extent I can push, that is noted by this third table. Now, this is the very interesting graph, which is known as the Hartford nomograms, based on Monte Carlo simulations. Monte Carlo simulations are basically they are the pharmacokinetic simulations in which we take the protein binding, the average weight, the average creatinine clearance, the eGFR, and all the different pharmacokinetic parameters in normal population, and then we add it onto certain softwares and we check whether what kind of dosings can we do in in certain cases. Now this is very interesting because if you see this, these got five dosing patterns are there, and the x-axis shows the increase in the MIC values from left to right, and the y-axis shows the probability of target attainment from 0 to 1, right? So let us say if I have if I have an E. coli isolate for which I want to give meropenem, and that MIC is 0.25, right? The MIC is 0.25, and what I'm doing in this case is that either of these infusions, whether I give 1 gram 8 hourly as a half an hour infusion, or 500 milligram 6 hourly as a half an hour infusion, all these different dosings and different concentration, this particular box shows a total antibiotic given to the patient in the entire day. So if it is 1 gram 3 times a day, so that's 3 grams. This is 500 milligrams 4 times a day, so that's total 2 grams. This is 500 milligrams 3 times a day, so it's 1.5 grams. This is also 1.5 grams, and this is a total of 3 grams. So if you see the first and the last dosings, they are the same amount of antibiotic given in the entire day, and the third and the fourth are also showing the same amount of antibiotic given during the entire day. Now, what happens when the MIC is changing? So when the MIC is only 0.25, all these dosing regimens will be able to get the 100% probability of target attainment. But what if the MIC rises from 0.25 to 2? Let us say you have got an E. coli isolate, that's an AMC producer, and you've given a third generation cephalosporin, and that induces that AMC and starts that hyper AMC starts breaking down meropenem also, and the MIC rises. So in this case, what happens? You see the blue line is the 0.5 gram every 8 hourly as a 1 hour infusion. So that's so in this case, the probability of target attainment in case when the MIC rises to 2 will be only just about 60%. So only 60% are the chances that it might have a probability of target attainment. So that means efficacy or the chances of survival might be 60%. But at the same time, if you see the green one, let's say that is this was the blue is zero point 0.5 as a 1 hour infusion, but you see the same dose, zero point 0.5 gram every 8 hourly as a 3 hour infusion. This is the purple line. So the purple line, so this is because this is a carbapenem, it's a time dependent antibiotic. If you increase for the same dose, 500 milligram 3 times a day, 500 milligrams 3 times a day. First one is as a 1 hour infusion, the second one is a 3 hour extended infusion. So if you see in the extended infusion, despite having the higher MIC, the percentage or the probability of target attainment is much higher as compared to the blue line, despite having the same doses. Now, what if the MIC rises to as high as 4? What do we do in such cases? So let us see these two graphs over here, the green line and the brown line. So in the green line, you see 1 gram TDS as a half an hour infusion. So the probability of target attainment is maybe around 70% over here. If you see like this, 70%. But at the same time, if you increase the infusion time with the same dose, the probability of target attainment is much higher, nearly as high as 100% or 1 in case when the MIC rises. That's the reason I'm saying that MIC determination is very, very critical. So at least in the labs, you can have a fair amount of calculation that in this dose, how can you increase the probability of target attainment if the MICs have increased. So that is why the clinical microbiologist must know these things so as to help the clinicians for the proper dosings, because the clinicians would think that only 500 milligram is good enough because that's what the MR told them, but it's not the case. You should keep it at least 1 gram 3 times a day as a 3-hour infusion. That is the minimum basic that should be done. Now, when we extrapolate all these Monte Carlo simulations into software, we get softwares like this TDMX software is there, and I'm showing this for meropenem. In this case, what do we do over here is that we put the patient's age, the weight, the height, and all these parameters. What is the dosing interval you want to keep? What is the MIC of the value or MIC of the particular isolate against meropenem? So these are softwares which are built on most Monte Carlo simulations. Once you enter all these parameters inside and do the calculation, and you want let us say PKPD target of 60%, right? That means 60% of times you want the MIC to be 60% of dosing intervals you want the MIC to be the concentration to be of the MIC. So in that case, what do you do? So in this case, you will see that the probability of target attainment, if I just take the first graph, I am giving 500 milligrams 3 times a day as a 1 hour infusion. So in this case, when the MIC is 2 and I want a probability of target attainment, the percentage of time of the dosing interval, the MIC has to be above 60% of the times. In that case, my probability of target attainment would be absolutely zero over here. But if I let us say over here, if I come over here, if I give 3000 milligram over 24 hours, that means 1 gram TDS as a continuous infusion, my probability of target attainment would be as high as zero point 0.8. At the same time, if I give 2 grams 3 times a day as a continuous infusion, then means my probability of target attainment will be as high as 100%. So always for the beta lactam drugs, the carbapenems always have a 3-hour infusion time, despite having, you can even use 1 gram 3 times a day, for example, for meropenem. But if you are having a increased infusion times or extended infusion times, your probability for the maximum kill for the particular bug will be really, really very high. So again, I said that the entire thing that I was talking about is that are the MICs related to dose of the antibiotics? So now this is where the answer lies, whether the CLSI is better or the EUCAST is better. So what CLSI does is CLSI has calculated clinical efficacies in cases of higher MICs for cefepime. So if the MIC of the particular bug is 2 or less than 2, this is the break point, right? This is the scale against which we measure whether a particular antimicrobial would be efficacious or not in the usual doses. So if the MIC is 2 or less than 2, what will be the usual dose? For cefepime, it will be 1 gram administered every 12 hourly. But what happens if this MIC rises to 4? So they do clinical studies in those patients where the MIC is 4, and they find that this patient will respond to cefepime if it is given as 1 gram TDS and not BD, or given as 2 gram every 12 hourly. So we have increased the dose, and we have in the first case we have increased the frequency of the antimicrobial. So from BD we have done to 3 times a day, or we are keeping it BD but we are increasing the dose. So similarly, when it further rises to 8 microgram per ml, in that case, we can give 2 gram administered every 8 hourly. So in this case, we are increasing both the dose and the dosing interval and the frequency. And they are also not, unfortunately, CLSI does not mention about extended infusions or continuous infusions, but this 8 hourly means even at 4, this would probably, this particular dose might be effective even at 4 if it was given over a duration of 3 hours of extended infusion. So that is what. So when these higher MIC values are validated clinically against higher doses or increased frequencies, these MIC values are called as susceptible dose dependent PKPD parameters. Whereas the UCAST does not take so much amount of load. What they simply say, this is the standard dose. When the MIC is in the susceptible breakpoint range, you give standard doses. But the moment it rises, maybe one tube dilution higher. So when it comes in the intermediate range. The intermediate range is the range where it may work, it may not work. That is the CLSI terminology. But when it comes to EUCAST, they call it SIE. That means susceptible with increased exposure. So in this case, what we do is we give higher doses when the MICs are one step higher or little higher than the usual from the susceptible breakpoint ranges. So what does all this balderdash means to clinician? The take home message for a clinician is that never ever divide aminoglycosides. Always give OD dosings except in certain cases, like for example maybe cystic fibrosis, when a patient is infected by a MDR pseudomonas, where you want to give tobramycin as maybe 7.5 milligram per kg body weight twice a day. Also, always give the beta lactam drugs like cephalosporins and all the BL-BLA combination carpenams over extended infusions, except in cases of lower UTI where you want maximum antibiotic to come into the bladder rather than to remain in the kidneys. And to prevent the development of resistance during treatment and achieve high probability of target attainment. So, if you want that your patient should have a good amount of antimicrobial kill in vivo, in that case, the same dose of 1 gram of meropenem TDS should be given as an extended infusion of 3 hours and not as a 30-minute bolus dose. So that's why, to be on the safer side, always give meropenem 2 gram IV as 3-hour extended infusion, because this dose will definitely have at least 100%, 200%, 300% probability of target attainment as compared to a 500 milligram TDS or a 1 gram BD dosings. Same thing goes for piperacillin tazobactam also. You have to give 4.5 gram only. And if you're giving it as 3 times a day, then it's a 4-hour extended infusion. And if you're giving 4 times a day, then it's a 3-hour extended infusion. So these are the PKPD dosings. That means we have increased the concentration of the antibiotic, and we have increased the dosing interval for the beta lactam drugs. Whereas in case of aminoglycosides, the PKPD dosing, despite what the MSDS or the material safety data sheet inside the vials they say, always give it as OD dose only and not as BD dose. And that is why CLSI, I would put it in the background and you go for EUCAST, because EUCAST have got their own labs and they have determined that amikacin dosings of 25 milligram to 30 milligram per kg body weight would be better PKPD dosings as compared to 15 milligram per kg body weight of amikacin. Also, that never to mix the concentration dependent antibiotics with the time dependent antibiotics in the same infusion. So never put the aminoglycosides and the beta lactam drugs in the same vial, because they are Y site incompatible. They cannot be given together. So Y site means there are two ports and one single input inside the patient. So they cannot be combined together at the same time. They have to be given during different time periods. Then what does this mean to the microbiologist? For the take home for them is to report the MIC values with interpretive criteria whenever and wherever possible, with a disclaimer that an MIC of 2 for teicoplanin can be more effective than the MIC of 1 for vancomycin in case of MRSA infection. So it does not mean that the MIC is same or the MIC is more or less that could be more efficacious. It will ultimately depend on your breakpoint to MIC quotient, for which I have recently uploaded a video on my channel also. So whenever and wherever possible, report only the breakpoint to MIC quotients, especially for the blood isolates, and cascade the antibiotics whenever possible, because don't give the clinicians a chance to harm the patient, because they may not be knowing the ill effects of inducer drugs like amoxiclav and your third generation cephalosporins, or drugs like imipenem, which are strong inducers of AMC beta lactamases, and they might cause a lot of havoc in the patient. So please avoid and stop the use of abuse of drugs like augmentin, which are extremely strong inducers of AMC beta lactamases. And of course, you have to insert a lot of footnotes about intrinsic resistances. Like if it is a protease, you have to write down as intrinsic resistant to colistin and not nitrofurantoin and all the drugs, which is classically given in the appendix B of M100. What is the resistance type? So interpretive reading, not as an interpretive criteria, also the interpretive reading also has to be done, for which again maybe I've already made upload a video on what is interpretive reading in Enterobacterialis, whether it's ESBL or AMC or both, because the resistance type will also determine what should be your choice of antimicrobial. The possibility of a particular isolate becoming resistant in vitro, again, the Heck case organisms, the Hafnia alveoli, Enterobacter cloacae, Citrobacter fundi, Klebsiella origines, Yersinia enterocolitica, Serratia. These are the bugs which are likely to become resistant during the treatment, especially, again, I'm repeating, when you're giving strong inducers of AMCs like augmentin and amoxiclav and your impenem. So these are very strong inducers of AMC beta lactamases. So these are the bugs that might become resistant during the treatment. We have to give the possible treatment options and the doses also, and the antibiotic posology, in which sequence the dosing has to be done. So normally the dosing, so if you're giving a combination antimicrobial, most commonly being an aminoglycoside and a BL combination like piptazo, so you should always start with the aminoglycoside, give it an old dosing over 30 minutes, and then you should give the beta lactam drug. And also you have to give oral options for de-escalation, and of course the cautionary notes on hospital infection prevention control, like the 5 modes of hand hygiene, and if it's an MDRO or a XDRO pathogen, in that case patient cohorting or patient isolation might be required. So with that, I'd like to welcome again all of you for the ASPICon 2025 that is going to be hosted and held by the Departments of Clinical Microbiology, Department of General Medicine, and the Department of Clinical Pharmacology at AIMS Mangalgiri, which is located in Vijayawada in Andhra Pradesh. And we have extended the last date of the early bird to 7th of July, but we cannot do it beyond that. And we request you to all register and go on. You can scan this QR code given over here, and it will directly lead you to the website, and you can do the registration. So we got around 7 workshops, and these are the topics that we have. That our scientific committee has decided. We got very interesting lectures coming up, very interesting discussions and deliberations for this particular conference. So I welcome you all to AIMS Mangalgiri for the ASPICon, 7th ASPICon, which is the national annual conference of the Society for Antimicrobial Stewardship Practices in India. With that, I thank you so much. Thank you.